Welcome to this video on early recognition of PCR and management. I am Dr. Ganesh from Nethradhama Super Speciality Eye Hospital. This was a case of routine femtocataract, and you can see that the side port and main incisions are being done. The main incision is a trapezoid 2.8 mm incision. The capsulotomy and nucleotomy are already performed here. A cannula is introduced to the side port and the flap is depressed to release it. Hydrodissection is performed and you can see the nucleus rising. Intracameral adrenaline and xalocaine is introduced to prevent intraopmeiosis of the pupil. Viscoelastic is introduced into the anterior chamber and then into the nucleotomy to separate the nuclear fragments because of the hydraulic pressure. This is a technique known as visco chop, which was described by me. And you can see that the nucleus has split into quadrants. We use the Centurion phaco machine, and the phaco probe is introduced into the anterior chamber. I use a flow rate of 60 and a vacuum of 700. And with a one-hand technique, the fragments are emulsified and removed. That is the first fragment which is being emulsified. And you can note that as the fragments are being emulsified, there is a sudden deepening and shallowing of the AC. So now there is a deepening and shallowing. This is the snap sign which occurs, and when this happens, you should have a high degree of suspicion. Withdraw the phaco probe and put in viscoelastic. Put in viscoelastic under the nucleus to tamponate the posterior capsule and also elevate and prolapse the nuclear fragments into the anterior chamber. The fragments are removed, and then you can note that there is a small bubble at the 6 o'clock position. We call that the bubble sign, and that is because here the BSS would have percolated into the vitreous cavity, and you can get this sign. The cortex is removed from the rest of the areas, and you come to the 6 o'clock position at the last and remove the cortex very carefully, and then you can see a small peripheral PCR which is there. There is no vitreous prolapse. And before removing the coaxial IA probe, you will have to put in viscoelastic into the anterior chamber to tamponate the posterior capsule and the anterior hyaloid face. Then a single piece IUL is introduced into the capsular bag, and then it is positioned in such a way so that the haptics are placed away from the peripheral PCR, and then the viscoelastic is removed with the coaxial IA cannula. Note that the IUL is very well centered and stable. The penetrating arcuate astigmatic incisions are then open, and that's the end of the procedure. Thank you very much.